when you look at the criminal justice system is not going to solve the heroin problem. It didn't solve the coke problem, it hasn't solved the marijuana problem. I mean, it puts a lot of people in jail, but we all, it would prove that is not necessarily the route we need today. Yes, we put dealers in jail, we go after those people that are trafficking, as we do. But, you know, as the president of Mexico said one time, they have the murder problem in Mexico because we have the drug problem in the United States. And if we don't attack the demand side of this issue, we're never going to solve this issue. Now, as far as my kind of specifics, you know, I think we're represented a lot of times. I'm also president of the State Chiefs Association, so I talk to chiefs around the state. The urban centers have had the heroin problem consistently throughout the last 10 years, but the suburban centers now are becoming almost the center of the problem in a lot of areas. I don't care whether you're in Hudson Falls, New York, or Poughkeepsie, New York, that had 10 overdoses in one weekend in Poughkeepsie, or if you're out in the western part of the state, or if you're with the sheriff that I was with from Ohio last week in a federal meeting, who lost 6 kids in a year. Both the valedictorian and salutatorian in their schools were killed with heroin overdoses. You don't have to look too far to find it. You know, when we look at the criminal justice system, once again, it serves a dual purpose. Hopefully we'll get traffickers off the street, but to be honest with you folks, a lot of people do not seek help unless they're introduced into the criminal justice system. I think Patty Farrell brought that up in her initial testimony this morning, that sometimes, you know, the arrest is not the worst thing that can happen. Because at that point, it at least gets people in the programs. I know many people who have had heroin addiction problems within their families who could not get their kids in the programs because they hadn't been arrested yet. Because they hadn't proved that they were addicted enough to get into a residential program. Or because there just weren't enough residential programs in the state of New York to handle that demand. Our drug courts have been successful, but they require money. And they require time. The diversion programs that we need to have our local criminal justice courts, because that's what we're seeing young people when they're first charged with shoplifting, when they're first charged with minor crimes. That is typically what we see heroin addicts involved with. That's what we need, those risk assessment things that we do with our juveniles and family court. We need to do that with adult court, but have another capability to have referrals to diversionary type programs to get to the problem before it magnifies. You know, in one family that I dealt with, people knew they had a heroin problem in the family. They did nothing with it. And 6 years later, they finally started to do something with it. And it's now been 9 years, and it's still the same problem. Because people did not address it at the time that they should have. You know, so, from our standpoint, if you look around the state, you know, our youngest people who have overdosed are in teens and high schools in the town of Colony. It's not a common occurrence, but it's not an uncommon occurrence. The thing that happened with Shenandoah Hall last week, in some ways, it's a positive that it happened because it brought the situation right out in the open. When you get that front page article in Time June, it's actually an important message. Because unfortunately, as the senators from New York knows, New York people are very aware of the problems they have. Suburban people have a habit of closing their eyes. And something like that brings them to the fold where they open their eyes and probably see the problem they have. But at the end of the day, if we can't get the educational component in place to stop this from happening before it happens, then the criminal justice component is just going to keep right on trucking along, and we'll keep 110 people gainfully employed in downtown. And whether it be the sheriff's department, the state police, or federal DEA, it will be more than enough work to go around. But if we don't keep pouring money into the treatment party, we're just going to have this thing to be a vicious circle right now. So I thank you all very much for inviting me to be part of this. I give all the credit in the world to the two parents who spoke here, because unfortunately that is what we need to regenerate, so to speak, to get the public involved in this. Because the habituates and the people aren't doing it. And we need the public involved.
Thank you. Well, so you're saying, and you know, I heard you saying two things. One, kind of an education and prevention piece is important. Is there anything else that we need to do from a law enforcement perspective to stop heroin from getting into our jurisdiction? Is there anything we should be doing either statewide or help that we could be giving to the municipalities to help the law enforcement?
Well, there's no question about it. When you look at a town like mine, I'm not an impact town. I'm a surrounding impact cities.
Right.
But if you look at rural America, if you look at all the townships across the state, we don't get a dime to enhance our drug enforcement efforts, to enhance our abilities to work from dealers, to enhance our abilities to really delve deep in that investigation. Unfortunately, we have a power to do it. But many of your total local town and villages out of the rural part of the state, get nothing from the city. You need to be able to spread some money around so that people have the ability or have the enhanced ability to deal with different agencies to make sure they're doing all they can do for enforcement. Our drug laws are supposed to be very strict. There's no question about it. They've been criticized for being too strict. We need to have the uncanny ability to just keep going after the drug dealers. But we also need our courts to be consistent on how they deal with those dealers. Because we're just putting them back out on the street and with no programming and nothing going on. And even with heroin, an addict, unfortunately, when you take a person that's been in that cycle for 4, 5, or 6 years, somebody mentioned before, there's not much of a life for them to go to after they get themselves clean. They have no job history for 5 years. There's no jobs out there. If we can't create an environment where they can be successful on their own when they complete that year-long program, we haven't done anything to help them along.
Sheriff Apple?
Good afternoon, and first of all, thank you for inviting us to attend this. You know, in the event of keeping from repetitiveness, but, you know, as the sheriff's office, we see it in the urban center, we see it in the suburban center, we see it in a rural setting, and it's everywhere. The heroin is not discriminating, it doesn't care about your ethnicity, it doesn't care about your financial status. We're seeing we're having more heroin arrests in rural areas than I've seen in 27 years. I just, you know, we're blown away by it. And yes, we can go out and arrest them. I can go a couple hundred yards from the building we're sitting in and make a heroin arrest and throw them in jail and fill another cell. But I don't really think that's the solution. And as a young officer, I thought it was. You know, we're out there with numbers, and now we're like, wait a minute, there's got to be other avenues we can pursue, and it's not just throw them in there and lock them up, and when they get out, hopefully they don't go back, because they do. And it is all cyclical. And the problem that we're having is that there really is no place. The diversion programs are few and far between, and they are in desperate need of funding. I mean, the people that sit behind me, I deal with on a daily basis. I talk to Father Young constantly. He recently approached me about starting a program in the facility where we can have heroin users and opiate users in the same areas of the jail. So, you know, we can address the problem as a whole instead of independently, because there's not the resources to do it independently. With me today, I have the Addictions Care Center personnel. We fund some parts of the program. We have them with us, and I recently called on them as a favor because I had a parent of a 19-year-old boy who called me, who I coached this boy for many years in baseball, a colony kid, and good old, you know, white kid from colony and middle-class family, and everybody thought life was great. Well, he's hooked on heroin, and he's hooked bad, and he's stealing from the family, and he's stealing from the neighbors. And what can you do? But the problem that I ran into with it is getting him help. You know, we were kind of on a waiting list, and I'm like, I can't believe this kid will be dead in 3 days, 4 days. It's only a matter of time before he gets a hot dose. The heroin's the cheapest it's ever been. You're buying it for $7 to $10 a bag. When I was a young cop in the early 90s, it was $25. Now it's $7 to $10. So for half the price, you're getting twice the bang because it's more potent, it's more prevalent, and it's cheap. And as prescriptions are getting harder, because as Chief Barry indicated, you've got iStop now, you've got an aggressive prescription drug campaign, you've got people dropping off their access pills to the prescriptions, you've got the FDA changing the composition of them so you can't shoot it up or you can't snort it up. So what do you go to? You go to the same type of drug, an opiate, and you get heroin. And it's very cheap and it's everywhere. And I can sit here and arrest them all day and throw them in cells and 10 people will jump in behind them and grab that cash. But to jump over to the diversion, I was told we had to wait 14, 17 days. Fortunately, I called him back and I'm like, this kid's gonna die. He's gonna die. And they got him down there. And they walked away, and we got him back. But that's happening every day. And without places to send them and without the programs available and the funding available to have these programs, we're gonna continue to pick up young kids. Whatever their ethnicity is, they're gonna be dead. And we've had far too many of them this year, just in the rural areas of the county. Last weekend, I was on my way to Christmas Street, right in Westerville, and I had to stop at a scene in the town of New Scotland for a 21-year-old Albany resident who committed suicide because of his heroin addiction. 21 years huge manifest explaining everything, but he was addicted and he took his own life. He knew he was destroying others. Earlier in the summer, we had a 21-year-old boy from Westerville. Again, middle white class child, addicted, parents had no clue. We went in the house, 40 bags of heroin under the bed, dead. So this is going to continue. We're trying hard to enforce. We're trying hard to push the education, being involved with the South DWI program in the county. You know, everybody thinks it's just alcohol, but there's a lot that goes with it. Because people are mixing heroin, they're mixing alcohol, and it is in fact a public health epidemic. We need to help with these diversion programs, we need to get funding out there. It's not just a matter of the cops going out and arresting. Later last month, I attended a program down in New York City called Law Enforcement Assisted Diversion. It's a LEAD program, it's a pilot program out in the city of Seattle. The Seattle Police Chief came to speak with us, as well as a lot of other advocates throughout the state, and they had law enforcement, district attorneys, addiction centers, and it's a new program. There's really no data available on it. They've taken they targeted an area of Seattle where the drug addictions were the worst and the crime was the worst, and they've got officers trained and they're picking them up and they're bringing them to treatment centers as opposed to bringing them to lockups. Is it going to work? I hope so. Something has to sooner or later, or we're going to continue to lock up grandfathers, fathers, sons, and it's just been generational and cyclical, and it's pretty sad when Albany County with 304,000 people, we have a county jail that will hold 1,049, and at any given day we're talking 780 to 850. It has about a 50-person swing every day with releases and new incarcerations. But at one point last year we had a grandfather, a father, a son. Where do you think the next child's going to go? So we have to get involved. I know the state, we look at different programs, we look at some that, I'm not blaming you folks, but we look at a lot that are warm and fuzzy, and a lot of people turn their head to the heroin. And I recently sat at a meeting with Mayor-elect Albany, and she was blown away at the stats and the stories that were coming out, and she said, why don't we know about this? And I think she'll try to do something locally as well to try and solve this problem and to be progressive with this problem. But a lot of people don't know, a lot of people don't want to address it because they just think it's that's a drug from the 70s, it'll go away, like, you know, the heroin or the cocaine and the crack and everything else, but it is all cyclical. And it's only a matter of time before you start locking up the crack addicts again. And, you know, when you talk about marijuana, but marijuana is a gateway drug. And when they're done with that, they just move on. And we have to address it. My heart's out for the families that have lost young kids. There's police agencies now throughout the country. Out in Minnesota, there was a story this week about officers carrying Narcan because it's that powerful to try to bring, you know, save people from addictions. Everybody's trying everything, but at the bottom line is it's going to come down to trying to get more diversion programs up and running and fund them properly the way they need to be funded, so we don't just throw people in jail. They'll sit in jail for 5-6 months, and we'll work back out, and they'll do it again, and it'll happen. And it's not solving the problem. And all we're doing really is just wasting taxpayer money on it. I don't think we have all the answers. It's going to be a little bit of, you know, a pilot program, test it, see if it works. If it doesn't, hey, I'm not ashamed to say, hey, that didn't work, we got to move on and try something else. Instead of just keep funding it and watching it fail. And we need to get these programs, we need to have the accessibility to get these people off the streets, so we're going to have a lot of deaths. Thank you.
Do you have any suggestions on the types of education programs that we could put in place that we don't have now? Or what do you think would work for getting the message out to our young people? You mentioned the PSA, but what else?
Well, I think we need to work with the state. This has to be a collaborative effort. It can't be just law enforcement, and the funding certainly isn't there for it to be just law enforcement. Some of the issues and the things that we do within the county with father young addiction care, we fund through asset seizures money because there is no state money available. So without that, we'd be in worse shape here. But I think, you know, similar to the DARE program, we've almost got to start to kind of reinvent that and maybe bring that back with a little different twist to it, you know, and get the kids involved in this and let them know that the hazards that are involved in it and the lives that are taking it. There's a place in Altamont called Choices 301, which is primarily related to alcohol, and it's a retired assistant chief or deputy chief from Colony actually that started it. And when you walk in there, it's very humbling to see the pictures, very graphic, and hundreds of pairs of shoes that they have on a rack of people who have lost their lives because of DWI. But it's almost gonna take something like that to show it, hardcore graphic pictures of this is what happens. These are the lives that it's taken. Because I was blown away when I saw what went on in Shenandoah. When I read that article about another person injecting, another child with heroin. I'm like, this is totally out of control. But it's everywhere. We're finding it everywhere. We're finding it in the city. We're finding it, a lot of school districts don't want to tackle it. We don't have an issue. The next thing you know, we're calling 911. Our paramedics are taking them out of school. And then a letter will pop up, warm and fuzzy with a letter, coding on it that doesn't really address the problem. It's everywhere. And we have to look at these kids, we have to get them involved, we gotta get the school districts more involved. The more and more meetings that I find, the more and more parents that are getting involved because they just didn't know. Marilyn, she has young children. So she hasn't really seen that high school, what's coming back from the high school, and she was devastated. And she said, what are we gonna do here? We've got to do something. And I think she will get to the table and do whatever we can, but that's just one part of the town. That's just one part of the state. This is not just Albany or state of New York. This is a national problem. And it's getting increasingly worse as we sit here at the table.
Sheriff, you just mentioned DARE. That was one of the most important programs to educate kids to be aware. Was it that successful, and could it be easily translatable for heroin?
I think it was successful. Unfortunately, as the sheriff's office, we had to terminate the program a number of years ago, basically due to funding. So we did away with it there. I believe some municipalities, I think Conley still does. We just were not able to fund the program, but I think it is a successful program. I think we might be able to, kind of have there with a twist and let them know what's going on. I might get them into the Conley program.
People said it wasn't a success because drug usage went up during the 2 years that the DARE was being offered. That was an unfair assessment. When DARE first came out, America was looking for the do-all and end-all to solve the drug problem. And the originators of the DARE program out in LA sold that as the do-all and end-all. Well, it didn't. So people automatically thought it was a failure. But the deterrence is something that you can never measure. And through act of that police officer in the school, or the school resource officer, who brings that message on a day-to-day basis, is still a very important message to the thousands of kids that go to school every day. And just because they don't do or they do drugs and play around the road, doesn't mean the program was a failure. But one more difficult thing to have with heroin, we see a lot of people starting heroin in college. It's not necessarily starting in high school level, it's starting in college level. And that is one of the scarier things, because you would think by then people would be old enough to make the right choices. But unfortunately, when it comes to drugs, as we've seen over and over again, that does not necessarily happen.
I'm looking at you, Vince. I'm sorry.
Before we
Sure.
move on, I just want to point out, and I want to thank you for coming. I wasn't sure exactly what you were going to ask today, but I do have members of the Addiction Care Center that I brought with me, who I mentioned earlier. But I also have a young gentleman who was a heroin addict, and he's in recovery. He's been in recovery for 3 years. And I asked him to come along with me just to listen, and if any questions pop up, and that's Chris Avato, he's behind me. And I want to commend him for taking the right steps 2 years ago and making his life more productive.
Would he be willing to testify a little bit?
I'm sure at some point he would.
Francisco.
Thank you very much. I just wanted to just take this opportunity to thank you on behalf of Mrs. Swords. Regretfully, Mrs. Swords couldn't be here, and I'm going to do the best I can to try to fill his shoes. But I can tell you, from my personal experience as a prosecutor, I've been a prosecutor for 15 years, and as has been laid out for you very clearly, there's obviously a heroin problem. I can think very clearly 3-4 years ago where, in my day-to-day work, I screen hundreds and hundreds of drug cases in my position as the Bureau Chief of the Street Crime Division, where we deal with all the drug cases that come through Albany County. And in screening of those cases, obviously the issue of heroin, it was around, but it was an old type of drug from the 70s. It wasn't a big concern here. But I can tell you now that as I review those cases on a daily basis, there is definitely a problem. It is almost every day when I screen cases, there is 1 or 2 cases that involve heroin. So it's clear that this is by the fact that we're having this dialogue that a problem around the state. Our office is, clearly, we try to be on the cutting edge of trying to come up with alternatives to incarceration, diversion programs. We've done that, but we know now that we're gonna have to do more because, you know, you've heard a lot today about public service announcements and different types of outreach, but I'm gonna amplify that just a little bit more. The talk about, there was such a rush with regard to controlled prescription drugs. The outreach was overwhelming because it was so easily accessible. You know, you could get it from your grandparents' cabinets, and you heard every type of public service announcement about it. What I think needs to come about from that is what happens now that we've clamped down on that, okay? What the residue of that now is that people are turning to heroin. You've heard from people in law enforcement that it's cheap to get. Obviously, if you go out and you buy prescription medication that, which now they have all the safeguards in effect, you have iStop, you have, which the sheriff has laid out. There's all these preventative measures in place to try to deal with it because there was so much attention to it. Now, as a result of that, if I can go out and buy heroin for $5 to $10, it's just that easy to get. So I think as part of that public service announcement that has been going on, there needs to be what's going to happen now that we've sort of clamped down on prescription drugs. Well, this is the residue. Heroin is back. And this cyclical effect you've heard about, we're in that high cycle. And, you know, our office, we're taking steps to try to, you know, that outreach, to reaching out to kids at schools. We do use some of our forfeiture funds to try to get that outreach out there, but it's got to come to you guys because you obviously will be able to get that message across the state. Obviously, we're working in a very small area here in Albany County, but I can tell you the problem is real, it's significant, and you know we're going to work with our partners in law enforcement to try to, you know, get that message across. You know, whether it's dedicating more resources to, you know, those outreach programs. But I know that internally within our office, we're going to have to dedicate more attorneys to focus on these type of cases because it's there. And I just wanted to just make sure that you hear about it, but I can tell you firsthand that the problem is very real, and it's one that there needs to be resources that are put into it so that they can start addressing it.
Why is it so cheap and so accessible?
Excuse me?
Why is it so cheap?
Well, it's about supply and demand, where when, you know, as far as heroin, it used to, the notion was that it would come from, you know, Asia. Well, now that they're getting it in Mexico and they're able to get across, I can tell you, in working with our federal partners, at least in the upstate region, their number of investigations that go into heroin investigations have almost doubled from a year ago. And these aren't just one person, these are long-term investigations that they're a part of. So obviously, it's being made more accessible. Obviously, there's always a war on drugs, but again, that demand is there, so they're going to supply it. And when you have competition, and the competition in this case is in the form of prescription drugs, you got to lower your price so you can beat that competition on the street. So that's why you're seeing the price being pushed down to push that product.
Thank you, each one of you. Thank you, Steve.
Thank you.
Thank you, Francisco. Okay, okay. Sure. First of all, thank you for being here, and thank Sheriff Green. You can probably provide as many answers to us as a lot of the witnesses. Just identify yourself if you like.
My name is Chris Sabato. I'm a recovering addict. I'm like sitting here listening to all this stuff, and the thing is I'm very stereotypical of a lot of the things that were said today. Grew up in suburbia, started off with other things, you know, prescription pills, stuff like that. And eventually, you know, it took over my life. And it's one of those things where I wouldn't wish the feeling I had when I was on that drug to my worst enemy, you know. It's something that, you know, it ruined my life for about 10 years. It took over my life. I like to think that I didn't lose anything. I basically gave it away, you know. And I went through all the stuff that was discussed today. The insurance, I was a government worker for years. I would only be allotted 3 days in rehab. I would leave. I would make excuses to leave. You know, detoxes and all this stuff. And it was just this horrible cycle I was going through all throughout life. Waking up every morning, feeling like, you know, clean crap. Doing illegal things to have to get the drug, you know, things like that I thought that I would never have to do in my life. And it's always things that growing up I would say, I'm never going to do this, I'm never going to be this person, and that's exactly what I turned into. February 2009, I had my first arrest. My first and only arrest for heroin and things that I did under the influence or to get heroin. I still used until about October of that year. So in my mind, even getting arrested and possibly facing prison or jail time still didn't deter me from putting the drug down. Did the jail time, got out. You know, I heard the word progressive disease earlier, and that's exactly what it was. I spent 4 months in jail, and I got out, and it was exactly the way it was when I had gone in. It wasn't until I got accepted into another program, another rehab, and I went into ACCA. And at that point is when I truly wanted to stop doing and stop living that lifestyle, and I was truly ready to stop, you know. I also am a firm believer in not just treatment of also 12-step programs. That's exactly what helped me get sober was a 12-step program. I wouldn't have been able to do it also without being in this program for, I think I was there for 6 months total. You know, I was able to pick up the pieces of my life, get my life back together, relearn how to live. I was a 29-year-old man who couldn't even make a bed. You know, and this is stuff that I was taught when I was a kid. You know, I didn't know how to do these things that I was taught by my parents, by my family. It's like I totally forgot everything because my whole life was consumed by this one substance for years. So, you know, I'm happy to be here. Thanks for.
Yeah, can you give us any advice on the early stages of prevention, what you think would be most important? The early stages when you were addicted, what treatment would have been most advisable quickly? We know that from the testimony at least that an outpatient is kind of a Band-Aid approach and we have to have
yeah, from my experience, from my experience, they had often tried to get me to do outpatient treatments, but I can only speak for myself. Like being an outpatient and still being out in the world wasn't the best thing for me to do. I needed a structured environment where I would go in and I would be on a rigorous schedule on what to do and be around other people for support. Because when I was still living at home, living with my parents or living here, I personally was not able to go to outpatient treatment in the morning or the afternoon and the other 21 hours of the day be able to stay clean.
If you can remember back to your high school days, were there times when an educational type of effort would have persuaded you not to try this drug? involved in drugs?
I think that for me, if the disease concept was brought up more, it would probably help me out a little bit better because, you know, for a lot of my younger years, just going out and partying was an accepted thing, you know, and it didn't really take a hold of me until years later that I really did have a problem. So.
Thank you for coming and telling us your story.
Thank you very much. Thank you, Sheriff. Thanks, Paul Mahoney. Who's the Assistant Deputy AG for Medicaid Fraud Control Unit.
Yes, thank you, Senators. Thank you to the committee and staff. I've covered my notes with notes from all the other speakers, so I'm going to try to keep on track. As you know, I'm Paul Mahoney, I'm Assistant Deputy AG and the Chief Assistant for the Medicaid Fraud Control Unit. I work for Attorney General Eric Schneiderman, who is the leading sponsor of the ISTOP legislation package to combat prescription controlled substance abuse and the associated fraud. And legislature passed it unanimously in the summer of 2012, and the two major components have come into play so far. The upscheduling of some of the controlled substances came into effect in February, and this past August, late in August, the mandatory physician checking of the prescription reporting database came into effect. End of early in 2015, mandatory electronic prescribing of all drugs will come into effect. Those are the key elements of ISTOP. There's very important other aspects, including disposal programs and educational programs. And so I thought that the committee is talking about heroin primarily today. I thought I'd, at the end of the day, take us back one step, if I may, and just talk about overprescribing. I'm not a physician or a scientist, but my learning over the past 2 or 3 years of working on ISTOP have led me to conclude that when we talk about turning to heroin, we're putting a label of turning as if that has significant pharmacological meaning. And I think we've now learned it isn't really as dramatic a step. It is a progression, as Senator Montgomery said earlier, of addiction, and you have drugs that are very, very pharmacologically similar. If you're addicted to a prescription opioid, the change in your behavior to use heroin is not that much different. Heroin seems to have, and I emphasize seems to have, a quicker addictive impulse to it. But we've also heard from, over the years, from people who have been on opioids who have become highly dependent in a very short period of time. I was talking a few weeks ago to an 85-year-old retired police officer who had been in 2 car accidents in the line of duty. He had had orthopedic surgery, and he took opioids. He took 15 milligrams a day. There are a large number of people who still get 80 milligram tablets as their initial prescription of opioid drugs. And that's a matter for physician education, and it's a matter for shutting down the supply, because those people who become addicted to the prescription drugs, yes, heroin is out there, but it seems one bit of learning I can pass along from ISTOP. It's only been in effect in fragments, in segments over the past year, and we don't have hard and fast data at all yet from the monitoring program. But we do know that there have been over 2.5 million, I think today, that's about a month-old statistic, so we're probably close to 4 million searches of the database, and close to 50,000 registered physician and healthcare worker users. So those numbers are right on track. That's what we expected. One of your colleagues during the discussions leading to passage of legislation said 22 million prescriptions, 18 million residents in New York, what's going on? And so we're still going to have a large number of prescriptions. It suggests that many people are single source dependent. We had spoken during the process of passing my stop about doctor shopping. And many people were eager to point the finger of blame at people with substance abuse problems who went from physician to physician to get multiple prescriptions, and we call that doctor shopping for shorthand. But I think we still have to address the problem of single source overprescribing. iStop does not prevent a prescription from being written. It creates knowledge and accountability, both of which are good things, but at the end of the day, the question of whether that prescription gets written or not is still a matter for a physician exercising sound judgment. We know that some don't. When I spoke to senators last year, there were a couple of cases I had to fuzz out the facts a bit because they were still under investigation, but we brought them to conclusion in the past year since iStop was passed. We've convicted two, and this is just the Medicaid fraud control unit, so I should emphasize that our main job is fraud, not pulling doctors off the street, not pulling drug dealers off the street. So our counterparts in uniform do far more of that than we do. We focus on road healthcare providers. We convicted two physicians, highly educated physicians. One was Dr. David Dreiser. Our calculations have been putting 150,000 high dosage pills on the street in Rockland and Orange County primarily. Dr. Arnold Roth, who was an at-home anesthesiologist, which we still haven't figured out what that means, but he managed to move 16,000 pills in 14 months. He's in state prison now. Each of them had 4 or 5 other people who were part of their networks convicted along with them. Dr. Reiser's wife was convicted of obstruction of justice. We have Nurse Jackie cases, as we call it. It's a shorthand because there's a television show in which a nurse, among many other things, as part of the television show, steals pills. That happens in real life, and there's real life implications of it. We have that in nursing homes and hospitals, including someone called Nurse Erin in Bath, New York, and Nurse Stephanie in Ulster County. I'm using the first names because they were all eligible for drug diversion programs, and everyone wants those to work. But make no bones about it, when they started out, they were deciding that they would get the pill, and someone's grandmother who had the prescribed pill wasn't going to get that pill. And so these are users, they're abusers, and they have substance abuse problems, but they have direct real-world effects. Many of the remarks today were fascinating, so I think it boils down to we probably underestimated the number of people as a society and medical community. We've underestimated the number of people who have addiction or dependency, and we're going to have to deal with that over the next few years. iStop will hopefully bring the trend down of new addictions, new people who are overprescribed, moving some people into education and treatment, but nonetheless, treatment, pill disposal will be critical as well. That 85-year-old man I mentioned asked me to look in his medicine cabinet and pulled out, because he meticulously filled each prescription fresh. He knew you weren't supposed to mix drugs and take half of this and half of that. So every time the doctor tweaked his prescription, he would get it fresh. The end result, 15 pill bottles in his medicine cabinet that when we put it together for him, filled essentially a takeout soup container for disposal. Because he knew, unlike, I was shocked when Mrs. Auerbach was saying that there's an elderly adult man who was traded pills for lawn services. And that's scary, and that's a very big shift from as father Young said in the 1960s model, being someone down the street. So I think we have to emphasize quality treatment. Medicaid fraud control over the years has had numerous instances in which we had to bring matters against substance and alcohol abuse treatment facilities because some are just well-intentioned but poorly run. They tend to be community-based without professional management, especially in their early years, and they can easily get overwhelmed by the amount of administrative process that can lead to other problems. But we've also seen people who definitely should have known better. Earlier this year, we did a $13.5 million settlement, primarily with New York Downtown Hospital, but with a group of other hospitals, who were using a substance abuse counseling revenue enhancement service. They hired an outside contractor to help them, quote, fill beds, close up. And we heard from some of the earlier witnesses today that discrepancy, or at least I heard discrepancies. Some feel that there's difficulty finding beds, especially long-term beds, and others seem to think there's plenty of beds, there's just difficulty getting the people who need it there. These programs, the program that we shut down, which is called Special Care, they had a simple expedient. They went around with a minivan and they found people laying in the gutter and saying, don't you want treatment? And they took any response at all for an answer, and they put them in the van and brought them to an acute care bed, which is about a $3,500 a day reimbursement from Medicaid. So the hospital was very happy to fill that bed, plus 5 or 10 other beds that were not certified with enough caregivers. So there is, when we talk about treatment, we have to emphasize quality treatment. Just the being in that bed for 2.5 days for those people who were brought in.